I'm happy to introduce Dr. Claire Godard-Sebillotte. She's relatively new addition to the MUHC and the RI. Her background, her training was mainly in France, including a Master's of Epidemiology. And then she came here and got a PhD. And her research program focuses on care trajectories of people with major neurocognitive disorders, and in particular, how to prevent their potentially preventable hospitalizations. And I have to say that if I had to summarize my research program, I think it would be very convoluted and people would look at it with a bit of skepticism. But in that sentence, as a clinician, I can just tell that there is a lot of opportunities to improve patient outcomes. And even looking at the title of your talk today, it's sort of the same thing. You're just like, yes, there is gold to be mined here in terms of improving the way we care for people. So I'll pass it over to you.
Thank you so much. And thank you all to be here. It's an honor and a pleasure to be here. I'm very happy. I joined the Corps recently, and I'm very happy to be able to introduce myself to all of you presenting my research. It's an incredible opportunity. Able to share to change the slides, so we're all set. So a short outline, I'm going to present a bit my own trajectory. Then the research I conducted actually for my PhD, and then my current future research and opportunities for us to discuss, and perhaps eventual collaborations. So I'm a geriatrician. I was trained in France. I have a license to practice medicine in Quebec since 2016. I have an MSc in epidemiology from France, from the Bordeaux School of Public Health. And I completed a PhD in primary care research here at McGill in 2020. And I started working at the MGH on January 31st, so very recently. And I just found my office at the Corps, so I'm very new. So my goals are to lead an academic program in healthcare service innovation for vulnerable older persons, to provide evidence to decision makers, to improve care trajectories and better the care offered to this vulnerable population. And I want to adopt a participatory approach involving patient partners, caregivers or care partners in the research process, and adopt an equity lens to my research. So my research. So first I'm going to present you the first study I conducted on hospital use of persons living with dementia. So persons living with dementia have twice the hospital use, emergency department visits, and hospital admissions as older persons without dementia. And this hospital use is associated with increased risk of delirium, falls, cognitive and functional decline, and long-term care admission and death. Some of this hospital use might be avoidable with appropriate ambulatory care. In the US, it's estimated that 20% of hospitalization of community dwelling persons with dementia are potentially avoidable. And reducing this avoidable hospital use and improving health services for persons with dementia are healthcare's priorities. However, in Quebec and in Canada, there was no data on avoidable hospital use in community dwelling persons with dementia. So that was my first objective, was to measure them and describe them. So I conducted a repeated yearly cohort study from 2000 to 2015 with the data, the health administrative data of Quebec that I did access at the Institut National de Santé Publique du Québec in Quebec City. I included over 190,000 community dwelling persons with incident dementia in Quebec. And I did measure hospital use and potentially avoidable hospitalization with 4 indicators. First, ambulatory care sensitive conditions, with two definitions, a general and an older population definition. Ambulatory care sensitive conditions are a list of conditions which could be prevented or reduced with appropriate ambulatory care. The older population definition includes additional conditions that are more specific to an older population, like hypotension, constipation, skin ulcers, or nutritional deficiencies. Second, I used alternate level of care hospitalization, which corresponds to persons having completed the acute care phase of their treatment, but remaining in acute care bed, mostly waiting for a long-term care admission. And finally, I did measure 30-day readmission. So on this graph, you see that during the year of diagnosis, we estimated that in community dwelling persons with dementia, 60 per 100 person year had at least one emergency department visit, the blue line, and at least 40, at least one hospitalization. And these trends were relatively constant over the 15 years. And the average number of days hospitalized during the year of diagnosis was 47. Pardon. Well, to represent it another way, and I'm not able to go back in the slides, but for 100% newly diagnosed with dementia followed for 1 year, 60 would have at least one emergency department visit, 40 would have at least one hospitalization, and on average and consistently over the 15 years analyzed, around 25% of these hospitalizations would be potentially avoidable. So in conclusion, persons with dementia have high hospital use, they have high avoidable hospital use, and there was a lack of improvement over the years. So this was a comprehensive measure of prevalence and trends of avoidable hospital use in community dwelling persons with dementia in Quebec. We did leverage this study to develop the Quebec surveillance system of dementia, and we included 4 new indicators to the InfoCentre. InfoCentre is a platform that allows all persons working for the Health and Social Services Network to access indicators for the population of their areas or actually from other areas. You can look on several health indicators across the population of Quebec, and you can stratify it by age, by sex, and you can look at your specific CIS or SUS of interest. So we did add 4 indicators to the InfoCentre. We are also producing knowledge translation briefs with the INSPQ. And for myself, I did gain expertise in administrative database analysis that I have used in the other studies. So then my second question was, how do we prevent this avoidable hospital use? And one of the first things that I did explore was health service intervention. So I was starting my PhD and I was thinking, of course, we must have already found how to prevent this hospitalization. And I was all the time asking my supervisor, so what is intervention that is working? And so at some point she was a bit bored with this recurrent question, and she said, actually, you should do a meta-analysis to see what's working. So that's what I did. So what do I mean by health service intervention? I mean any intervention aiming at improving practices and organization of care as defined by the Effective Practice and Organization of Care Cochrane Group. And how would this intervention reduce avoidable hospital use? For example, case management could improve the coordination of care, and self-management could improve caregiver abilities to care for behavioral and psychological symptoms of dementia. However, their impact on hospital use in persons with dementia was unknown, and that was one of the objectives of my PhD, was to answer this question. So I conducted a systematic review and meta-analysis. I included 17 randomized controlled trials with over 5,000 persons with dementia. I did include unpublished data for certain trials, and they represented 65% of the included data at the end. And most of the intervention had either a case management or self-management component. So on this slide, you see the pooled risk difference for each of the synthesized outcomes. So I did synthesize a proportion of having at least one emergency department visit at 12 months or at the longest follow-up, and proportion of persons having at least one hospitalization at 12 months or at the longest follow-up. The black colored error bars are the confidence intervals, and the gray shaded bar plots are the predictions interval. And what I want you to see is that confidence intervals as well as prediction intervals largely cross the null effect line. So prediction interval included both positive and negatively clinically relevant effects, meaning that we could expect in future settings with the same type of intervention either an increase or a decrease in service use. So in conclusion, there was no health service intervention beyond usual care that was found to reduce hospital use. It was a comprehensive synthesis of the impact of any health service intervention. I was proud to have a very effective author contact strategy, which actually saved my meta-analysis, because at the beginning, I had so few published measures and measured with very different ways that actually I couldn't do anything. So I had a lot of motivation to have a very effective author contact strategy. And I used prediction interval to conservatively interpret the range of expected treatment effects in future studies. Mainly randomized controlled trials. Only randomized controlled trials were included. So then I looked at primary care continuity and whether primary care continuity could have an impact. So by primary care continuity, I refer to relational continuity. So the relationship between a family physician and a patient that extends beyond specific episodes of illness. How would primary care continuity decrease avoidable hospital use? So it could improve the management of chronic conditions or improve the detection and treatment of acute exacerbations. So the impact of primary care continuity on hospital use and avoidable hospital use in persons with dementia was unknown. So I did conduct analyze an observational cohort with inverse probability of treatment weighting using the propensity score, a method I'm going to briefly present in the next slide. I included over 22,000 persons. 66% of them had high primary care continuity, and I did measure the same outcomes as I previously presented to you. So in non-randomized intervention, which is the case of primary care continuity, no one has assigned people to primary care continuity, and especially not randomly. If we were to compare persons here represented by blue dots that are exposed to high primary care continuity compared to persons exposed to low primary care continuity, and if we were to compare their outcomes, we would, it would lead us to a biased impact estimates. Indeed, exposed and unexposed might differ. And for example, the persons in high continuity group might have more diseases, which explains why they are so thoroughly followed. They might also have more visits to the emergency department. Simply measuring the difference in outcome between the exposed and unexposed lead to the conclusion that persons having high continuity have more emergency department visits only because this association is confounded by comorbidity. So what I did use as a method was inverse probability of treatment weighting using the propensity score, which allows creating a weighted sample in which exposed and unexposed groups are comparable on measured baseline characteristics, especially on measured confounder. And under a set of other conditions, this allows strengthening impact estimation from observational data. I was able to show with this study that if we were to treat 23% with high primary care continuity for 1 year, we would be able to prevent 1 emergency department visit. And if we were to treat 30% during 1 year with high primary care continuity, we could prevent 1 hospitalization. So in conclusion, I was able to show a negative, large, and statistically significant association between primary care continuity and hospital use. I conducted a robust estimation of this association, even though it was in the observational context. And I used methods allowing strengthening causal inference. And I just presented you the inverse probability weighting on the propensity score, but I also applied the target trial framework, and I did conduct quantitative bias analysis to test the robustness of my results. And this third study allowed me to gain expertise in causal inference that I aim to use in the future. So now I'm going to present you my current research and my current and future research. So equity in care for persons with dementia. First study that I already conducted, and then I'm going to show you the prolongation that I envision. So there is scarce and conflicting evidence on socioeconomic inequities in the care of persons with dementia. In Canada, where we have a public universal health insurance system, there is actually only 1 study which described the association between deprivation and dementia care. This British Columbia study showed that there was association between low income and less counseling, referrals, and more antipsychotic drug prescribing. In addition, there is no specific targets to address inequities in dementia care in Canada, including in the latest and only Canadian dementia strategy, the 2019 Canadian dementia strategy. And we know that plans implemented at the population level without targeting high-risk groups are at risk to increase inequities. So it seems that there is an urgent need to describe the association between socioeconomic status, care received, and health service use in persons with dementia in order to ensure equity across all levels of socioeconomic status. So my research question was, is there a difference in care and health service use across socioeconomic status? So I conducted a repeated yearly cohort study from 2000 to 2017 with data extracted from the Quebec Health Administrative Database. They are also extracted from INSPQ, Institut National de Santé Publique du Québec. I included over 190,000 community dwelling persons with dementia. And I measured 27 care and health service use and mortality indicators during the year of diagnosis, grounded on a framework of primary care quality and health service use in persons with dementia that we did develop in our team. We stratified the analysis by socioeconomic status. We used the 5-level Quebec Material Deprivation Index, which is a composite measure of the level of education, employment, and income of the census dissemination area level. So it's an ecological variable. And then we performed a graphical assessment of the differences with several rounds of expert consultation. So here you see the age standardized rates over time for 4 indicators. The blue lines represent the rates for the lowest and highest socioeconomic status. On the top left corner, you see that for having at least one emergency department visit over the year of diagnosis, the rate for highest socioeconomic status seems to be consistently lower than the rate for the lowest socioeconomic status. And this same pattern seems to be present for at least one hospitalization, one prescription of benzodiazepine, and one prescription of antipsychotic, which are both potentially inappropriate medication for persons with dementia. On this slide, you see the differences across socioeconomic status for during the year of diagnosis to be admitted to long-term care, and the mean number of cognition specialists. And here we can see that persons with lowest socioeconomic status have more admission to long-term care, and that the mean number of cognition specialist visits were lower for the lowest socioeconomic status, who had less visits to cognition specialists. For some indicators, we did not identify any difference across socioeconomic status. It was the case for mortality within 1 year, the mean number of visits to primary care physicians, at least one prescription of anticholinesterase and memantine, which are the specific medication for dementia. So in discussion, we concluded that there was a difference across socioeconomic status for most indicators, which might signal inequities. There are limits to this study. First, the measure of socioeconomic status is an ecological variable and not an individual variable. There is a risk of ecological fallacy. And in addition, the differences we showed, so this unequal use of services, are not for sure inequities, and they might signal different needs. And indeed, especially in this study, we did not adjust on potential confounder like stage of dementia or comorbidities, but we could speak about the value of adjusting and on what we want to adjust, and especially remembering one recent seminar, course seminar with Dr. Jackson, where we discussed like what do we want to adjust for and what do we want like to make these appear in our descriptive analysis and why. So the next steps are to interpret these differences through expert consultation, and further research should investigate this difference to better understand their underlying causes and the best way to tackle them to offer equitable care to the entire Canadian population with dementia. Now I'm just going to show you a little aperçu of coming studies. So we've been granted funding to conduct a study on the impact of COVID and the COVID pandemic on the care and use of services for persons with dementia. This study, we're working with 4 provinces, with Alberta, Saskatchewan, Ontario, and Quebec. We adopt a participatory approach. We include Alzheimer's Society, Dementia Advocacy Canada, and the Ministry of Health of each of the provinces. And we also include partners, patient partners and care partners in the process, and especially in the formulation of the research question, discussion of results, and writing of articles. So we have 3 persons with dementia and 13 care partners, and we did try to increase the diversity of these patient partners and care partners in having people that are living in the community and other living in long-term care facilities, having Anglophones and Francophones, having rural and urban persons, and a person that do identify as racialized. So this study is a mixed method study. The first objective is to measure the impact of the pandemic on health and social service use, infection rate, and mortality of persons living with dementia in the community and in long-term facility. And this will be conducted through quasi-experimental study using administrative databases. The second objective is to understand patients living with dementia and care partners' experiences and expectations with health and social services, access and use in terms of human rights. And that is actually a research question that was modified through the work with the partners and the patient and the care partners who did introduce this notion of human rights. For this second objective, we will use explanatory qualitative multiple case study and use surveys and interviews. And the third objective will be to generate and disseminate evidence-based and actionable recommendation on effective strategy to tackle the current wave of the pandemic and prepare for future waves. And we will integrate the qualitative and quantitative results and conduct deliberative workshops. So the objective one, which is the quantitative study, is already well advanced in other provinces, and in Quebec, we're still at the stage of waiting for the data to be accessible. The request is however in advanced stage. And so we plan to conduct a quasi-experimental fixed cohort design using historical control. So we have access to data in 4 provinces, and we want to compare every person age 65 plus with a diagnosis of dementia on the 1st of March 2020, which will constitute the exposed cohort compared to the historical controls, the unexposed periods of March, December 2018 and 2019. And we want to measure the same, actually, 27 outcomes that I presented before, the framework of dementia care and primary care outcome that we've developed. So hospitalization, ambulatory care, medication use, long-term care, and home care. And we want to use to compare this health service use and mortality in exposed and unexposed cohorts using inverse probability of treatment weighting to try to have as alike cohorts before the exposure starts. So I'm part of the greater study. I'm part of the quantitative study, and in Quebec, actually, I did obtain a small funding to have a focus on equity. So my hypothesis, which was generated through extensive evidence coming from other countries, but also from Canada, was that sociodemographic health characteristics and patterns of health service use of persons with dementia differ across race, socioeconomic status, and sex, and that the pandemic period might have exacerbated these existing inequities. And so I wanted to describe the sociodemographic health characteristic and service use pattern of community dwelling persons with dementia according to race, socioeconomic status, and sex, and to measure to which extent race, socioeconomic status, and sex modified the impact of the pandemic on mortality and health service use of community dwelling persons with dementia. So as you might know, in Quebec, we don't have access to individual level variable on socioeconomic status of position, race, or and gender. So I did some of exploration of what was possible. That's the first index that I actually already used, which is, and some of you might be familiar with it, which is the deprivation index, the indice de défavorisation matérielle et sociale, or indice de Pampalon, that is freely available on the NSPQ website, and which allows to link a person's 6-digit postal code that we find in the FIPA database, where we have the address of everyone in Quebec, and to link that with indice de défavorisation for the which is for the entire, there is a version nationale for the entire Canada, and one which allows to do a cross-provincial comparison, and one only for Quebec when you just want to do comparison within Quebec. actually the macro, the SAS macro that they provide allows also you to code some rurality variables. Then I looked at the marginalization index. It was developed in Ontario and has also a national, like a version for the entire Canada. And it allows you to link the 6-digit postal code of the person to the dissemination area characteristics. And then it's also freely available on internet. There is a recently released 2016 version, and allows you to associate each person and its dissemination area for the dimension of the marginalization index, which have been renamed in the 2016 version in household and dwellings, material resources, age and labor force, and immigration and visible minority. And this index is, for example, accessible at ICES, which is the administrative database in Ontario. And so, the two previously presented index are not already linked in the Quebec database when it's accessed through the Institut de la Statistique du Québec, which is the way I'm going to access the data for this COVID study. And that's why I thought that I could perhaps link each person to its dissemination area characteristics, and especially the 2016 census variable, where, for example, there is one variable, which is the proportion of persons who self-identify as visible minority, which is defined by Statistics Canada as a persons other than Aboriginal peoples who are non-Caucasian in race and non-white in color. And my envisioned approach would be to do some kind of multi-level analysis to measure neighborhood effects using the Pempelen index that I already used and I just presented, and the census data for the proportion of population who self-identify as visible minority. Another project that I'm currently submitting a request for funding at the spring CIHR competition is around e-consult and how to improve access for all older persons living with frailty through e-consult. So e-consult is named in Quebec as Conseil Numérique, and it's a way to communicate between the family physician and a specialist in an asynchronous way, which means that actually the family physician writes an email to the specialist, and the specialist is supposed to answer within 1 week. And actually the previous study on the implementation and impact of e-consult in Quebec showed that most of answers arrive within 2 days. And this e-consult has been first pilot tested in 3 regions in Quebec. And since last year, it has been extended to the entire province. And e-consult already exists in Ontario and in New Brunswick, where it's already extended to the entire province. And this e-consult is also funded in Quebec. The doctors can bill to do that. So for this study, I'm applying with 3 provinces, including Ontario, New Brunswick, and Quebec, and several collaboration with Doctors Association and Ministry of Health. And so what we want to do in this study is to extend the e-consult to persons living with frailty. So currently, this platform of tele-expertise is already running for the entire province, but we want to see how we could adapt it for persons with frailty. and we envision to develop that in 4 phases. First, to assess the needs and service offered in Quebec for a frail older person. Then to co-design with all the stakeholders that are involved in the care of persons with frailty, an adapted version of e-consult for this specific population. Then to measure measure the implementation and start measuring the impact of the e-consult on the care and access of persons with frailty, and then developed the necessary tool to scale up e-consult for frailty to the entire province and to make it routinely available. And for all these phases, it's still not completely clear for me how I'm going to assess the impact, especially because the database on e-consult does just have the intervention group and we don't have the control group. So I'm still not completely sure on how I could, through administrative database access, identify who has a family physician, who is using Conseil Numérique, and to try to assess an impact through causal inference methods. That's the first step, and how I'm going to assess the differential impact across either socioeconomic status or for minorities, or for across gender, or for population that are more rural or more urban, is also still in question, especially with the numbers, because I'm not sure whether I will have enough numbers for each of these strata. But what I for sure I want to push is to, because it's a mixed method study also, so I want to push that on the qualitative side. We're sure that we try to include a diverse sample of people to see the different impacts for them of the implementation of in-consult. And actually, that was my last slide. So thank you so much. And I'm very happy to discuss further with you and to answer all your questions. And I'm very happy also if you have answers to my methodological problems and limitations.
Thanks, Claire. That was a really, really nice talk. Impressive amount of work that you've done. So I'll try to chair the question session. Start with Kaberi, who has a question.
So thank you so much, Claire. That was an excellent talk, and it's really neat to see a new core member embarking on such a nice research program that combines health admin data and qualitative research, as we had discussed before, and as you show it so nicely here. I had a question about the prediction interval, which I'm not familiar with. So if you could kind of describe that to us and how you computed it, I'm very, very curious.
So I had to relook at my notes, to remember what it was exactly. And I have to say, disclaimer, I'm not a specialist of that. And at that time, one of the co-authors was really pushing for it, Tibor Schutzer, who is a statistician working in the family medicine department, and who knows this stuff in statistics and epidemiology and all of that. And so he pushed for that because he was saying that, so how do you compute it? It's very easy, because if you use the R code, it's just in it, and you just add the command predict and it's doing it. So that's very easy and to do it. And so the aim of the prediction interval is to be more conservative and to try to assess what would be if we were to use the same intervention, assuming that we think that we had an homogeneous set of intervention in our meta-analysis, and that it made sense to pool a pooled effect, which can, of course, be questionable. So if we were to have an homogeneous intervention, and if we think that we are measuring the effect of the intervention, the prediction interval is supposed to predict what it could give as an outcome on the same kind of population if we were to reproduce this intervention in the future. How it is computed mathematically, I have really no clue, and I can look it up and let you know. And I have a chance that it was not asked at my defense, but yes, it's really the idea to what would be the effect in a future context with the same kind of intervention of the same kind of population. And it should be best practices in meta-analysis, and we should all do that.
Maybe Elham has a comment, although maybe good thing that I wasn't at your, at your defense, because I would ask the question. But yeah, thank you.
So Joseph Musa has a question on the chat. He wants to unmic, he can unmute, he can ask it, or I can ask it from the text. So he comments, great talk. You mentioned performing a bias analysis for the first study. Can you elaborate on the methods for the bias analysis and your findings? What were you aiming to correct for? Unmeasured confounding, measurement error, missing data?
So for the bias analysis, I did do the I'm missing the E value, I think. I'm very sorry. So it's the way it's you try to estimate what strength of association between a potential unmeasured confounder you would need to have with your exposure and your outcome after having adjusted for all the confounder that you did adjust for. What would you need as a strength of association to undo the statistical analysis that statistical association that you were able to present? So, for example, here I was able to show that there was that there was an association between primary care continuity and hospital use. So, what would be the strength of the unmeasured confounder that I would need to be associated with my exposure and my outcome after having adjusted with all the confounder that I had? And the strength was around 2, and we did conclude that, and after to interpret this E value, you actually just discuss it. So you say, from the literature, I think it's plausible or it's not. And I guess that it's easier to publish if you conclude that it's unplausible. So we did conclude that it was unplausible, even though like that's completely questionable. We did say we would need to have a unmeasured confounder that would not be linked to any of the things we've been adjusting for with an association of 2. And we did adjust on all the previous service use. We did adjust on all the comorbidities we had access to. We did adjust to so many things, but for sure, we did not adjust on whether persons had a caregiver at home, for example, which might not be associated to anything that we did adjust for. So for sure, we don't know. So we don't know, and we did publish in a clinical journal, which I guess are more relaxed on the causal inference assumption and on whether you've been adjusting on all the confounders. But for sure, the association I'm showing might actually be completely confounded. But it's what we did conclude, we did conduce, and it's recommended. And I think it's and I'm very sorry to forget what the name is, but I think it's the E value, and it's a Wonder Wheel which who developed it.
He gave us a talk on it, actually. Yeah.
Ah, okay, good. Bon. So, and it seems to be something we should do, even though in the causal inference world, there is a discussion because some say we shouldn't. So anyway, we did follow this way.
Okay, thanks. Yeah. Vanderweel gave a talk at the seminar series, I think, actually, about this exact topic. So you're in
Okay.
good company.
I hope I did not destroy too much the essence of it.
No, I think that's right. I think it's a metric that has, I think, some value, but doesn't overcome all the limitations of causal inference in observational data. So Angie has a question. Shoot.
Great, thank you so much. Can you all hear me?
Yes.
Okay, fantastic. Great presentation. I had a question. I was wondering if you're familiar at all with the work that the Institute for Healthcare Improvement has done on reducing readmissions. When you spoke about the meta-analysis you conducted at the beginning of your research, looking for sort of published evidence of interventions that have improved readmissions, I had a bit of a red light pop up in my head, because I know a lot of quality improvement practices have been done on this topic, but one of the things that bothers me to no end and why I'm in a master's program for epi right now is because none of those interventions are really published published in literature that epidemiologists look at. So yeah, just wondering if you were familiar with any of the work that IHI has done on readmissions.
No, I'm not, and thank you so much.
Damn, okay.
No, and especially because I did looked only on randomized control trials. So I guess they did not conduct randomized control trials. So, but for sure, I did not include any gray literature, and even as I showed, like even for my meta-analysis and the way I did choose like to do only randomized control trials, like very few was actually published. And at the beginning, I was like, no, but all this work, and actually I will not be able to pull any effect because people do measure it at different time point and with different ways to do it. So I really did have to contact every author, and I had to be very pushy to be able to conduct it, because at the beginning I had no analysis to be done because yes, I couldn't pull anything. Like all the measurements were done at different time points or in different ways, including or not including the zeros, for example.
Yeah, I've put some links in the chat. There's a topic page about readmissions. There's also work that's been done in what's called the age-friendly health system, that's sort of trying to bring together lots of different hospital systems to work on making age-friendly care a thing. And so, you know, not exactly about dementia, but definitely an important component of that work. So thanks again for the talk.
Thanks. So maybe I'll ask a question while other people are typing away. So I thought your first project really underscored a problem, I guess, and that it's a pretty stable problem. It's not going anywhere. Then you showed the signal for continuity of care in the primary care setting. Correct me if I'm wrong in my interpretations. Were you tempted to pivot? I mean, demonstrated that with observational data. Were you tempted to pivot to some sort of intervention or trial to see if that's really the case, or you think that that's sort of a established or believable effect and the government should just try to improve primary care continuity and access? Is one question I have.
Thank you so much. I think I haven't been tempted to move to a trial because I'm a firm believer in observational, like in the debate on whether we should do everything RCTs or whether we should do only observational. I'm very like, I'm advocating for observational because I think that in such a control setting as an RCT, we are not going to show anything that is going to be generalizable to the real world. And of course, when you have tons of millions of money and you're going to have, yes. So I for sure, I did not think about intervention for sure. The second thing, and I'm someone who is very, very suspicious on my results and on so I think my first reaction was more, how? And how is it working? And isn't it because they are fundamentally different people? And then also, like, what do you do with such a result? Like, you present that to clinicians and they say, yes, okay, like, of course, like, if you're, because I was measuring the year prior, my primary care continuity measure was people during the year prior who all the time had seen the same physician in the people that had seen at least twice a physician. So I present it as a primary care continuity measure, but actually in my head, I've all the time felt about it as an access measure, because if in the year prior, you all the time have been seeing the same physician, it means that you were able to see your primary care physician when you needed it, which is one of the greatest problems in Quebec. It's that when people get ill, they cannot see their primary care physician. So I think that in my head, I was imagining presenting that to clinicians who would say, of course, if you can see your primary care physician, you don't go to the ER. So why you needed to do all these fancy models to prove something that we actually see in ER every day? So yes, I think my reaction was more, okay, how, like, first, isn't it obvious? Then how does it work? And then something I haven't presented because I still don't really understand is one other result that I have is that when I stratify by socioeconomic status, I see that actually people who have lower socioeconomic status, living in a neighborhood of lower socioeconomic status, I show that they have greater continuity of care with a measure that encompasses all types of physicians. Easy to explain. Actually, the richer do see neurologists, do see cognition specialists, so they are more referred, and so that's explainable. But then I have another measure of continuity that is just for primary care, and there I show that persons living in neighborhood of lower socioeconomic status have higher continuity of care. So I have trouble explaining that to me. So it would mean that they have less access to walk-in clinics. I'm not sure how I can explain that. And I'm not sure whether it's good or bad, because normally, like what the Canadian Conference Consensus recommend for persons with dementia is to be mostly cared in primary care. The rationale being that actually, for most cases of dementia, a good diagnosis, a good accurate diagnosis can be made in primary care, as well as initiating the treatment and the follow-up. So is it better to have high primary care continuity? So actually, I think that something that would be very interesting is reproduce this study and see how socioeconomic status moderate the effect of, modify the effects of primary care continuity and whether it does.
Can I just make a comment, actually, Claire? Because I think maybe one thing to think about is, because I think your assumption was if you had a lower socioeconomic status, you should have less continuity of care, like that would go along with all the other bad metrics.
Yes.
But in some low socioeconomic status communities, there is a well-functioning or reasonably functioning community health center with a decent complement of social workers and physicians and nurses and so on. So my husband happens to work in one of them. So you could imagine in some instances, the organization of care might be better or comparable than another neighborhood with maybe higher SES, less of a well-functioning community health center where people are sort of seeking care and in different centers. So it may take a bit of ground truthing to look at the organization of care. Yeah.
Yeah, thank you.
Thank
you. And pardon.
Go ahead.
No, just to say that I think I still don't really understand my results. And one of the things that I wanted to do, and then I applied for a grant, a dissemination grant. I wanted to conduct a deliberative consultation to assemble around the result of my PhD persons living with dementia, their care partners, and then physicians and ministry representative to discuss these results and to try to understand, okay, what do we do with that? Like, are these results stating that if we increase primary care continuity, we're going to improve the care? And if so, how? And how do we improve primary care continuity?
Yeah, I think, I'm not sure if everyone would agree that the observational data you presented is sufficient and that randomized trial data isn't needed. I agree with you that it seems so intuitive, and so it must be true. But as you just mentioned, even if we accept it as truth from the observational propensity score matched results, there remains the question of, okay, well, how do we benefit from this knowledge? How do we implement, how do we improve the primary care continuity? And that remains an opportunity for randomized trials. So I think by pursuing an intervention-based randomized, maybe cluster randomized trial or something like that, you could simultaneously kind of provide, overcome any residual concerns about residual confounding and that could not be addressed by the propensity score matching, and still address the pressing need, which is, okay, well, how do we get there? What is the best way to get there? I'm not surprised that the primary care physicians are like, we know this already, but really the stakeholder of interest really is the government to say, like, we need to help them, implement continuity of care in a way that's effective. My last comment relates to another one of your projects, which was where you were exploring sex and race and SCS. Another thing to consider in Quebec specifically might be language, if that data is accessible through your data sets, particularly, well, just then in terms of an interesting contrast might be in the rural or en région, or basically outside of the bilingual centers. And this is particularly relevant, I would say, in the context of Bill 96. So there may be important signals that you could demonstrate that, in fact, access to care on linguistic lines has adverse effects.
All right, thank you so much. That's a very good, very, very interesting avenue, and very interesting also how the partners with whom I'm working on eConsult did speak about language barrier in Ontario, but did not dare, I don't know whether we need to dare, but to dare in Quebec. So very interesting. That's and for sure we have that in the census. So if what Institut de la Statistique du Québec told me repeatedly, which is that I'm going to be able to link with the census data, I could explore that.
Okay, so we're at the top of the hour. That was, again, a really great talk. I'd love to talk with you more about what you're doing and actually to better understand how you access all that rich data. So thanks again. Tina Wilson says a thank you. Great talk. High praise. So yeah, thanks a lot. We'll see you around.
Thank you so much for the invitation. It's well, incredible opportunity and so interesting to engage with all of you in your question. Thank you so much.